Dr. Alexander graduated from the University of Minnesota Medical School and received a clinical research design and biostatistics master degree from the University of Michigan. He completed his internal medicine residency at the University of New Mexico and a geriatrics fellowship at U of M. He's pretty well educated, it sounds like. He is a past research fellow at U of M Institute of Gerontology, and he is board certified in internal medicine and geriatrics. Currently, he is the director of the VA Ann Arbor Geriatric Research Education and Clinical Center. Today, he will be giving a talk on reducing fall risk for older adults in the real world. Please give a warm welcome.
Thanks, I appreciate the invitation. Wow, the lights, cool. Oh, I'm being taped, that's why I'm so lit. No, I'm not lit, actually. Thank you for all coming. I appreciate the fact that now it's about an hour, is it an hour or hour and a half postprandial? And your splanchnic pooling is going well, and you're probably going to, hopefully you will not fall asleep during this thing. I'll try not to. I'll try not to let you. How many people here are physicians? And how many people are nurses? How many people are administrators? Social workers? Wow, cool. Therapists. I should probably change this term, but I call myself a FONT, a friend of nurse and therapist. Okay? I should probably add that social workers and administrators as well. And people are from assisted living, long-term care, hospital-based? No. Yeah, a little bit. So a lot of what I'm going to talk about is community-based that I think you can probably, somehow relate to your particular situation, but I think I have some data there specifically focusing on facilities that are more supervised. I'm not sure what the right term is. So, I have no disclosures. Let's start with a case. Now, we ran a nationwide fall injury reduction program in primary care, so that's called the STRIDE study. So we have a 90-year-old with walking and balance problems, fearful of falling, no recent falls, small steps, forgetful, and mumbles at times. Doesn't do a speech exercises, uses a cane for more than 10 feet. Referred to PT recently for gait strengthening assisted devices, past medical history, lumbar stenosis, leg weakness, glaucoma, hard of hearing, meds, cinnamon, hydrochlorothiazide, Norco, pain when upright, urinary incontinence, soft speech, mass faces, slow finger and arm movements, right wrist rigidity, blah, blah. It's a lot of indications of Parkinson's. We'll talk about what we're going to do with him. His SPPB, the short portable performance battery done in the community. I don't think are people out here doing that? It's a measure of multiple times out of a chair, walking and standing. I don't think many people in a long-term care facility or assisted living can do such a test. So this person didn't do very well either. And a mini cog, which also a number of your residents probably can't do, he lost points on the clock test. So some cognition problems as well. That's the kind of patient that maybe a little bit less impaired than what you have, but maybe not so far away from what you have. A main intervention was a spine clinic PT and the issues with cognition and hearing. Notice the focus was on lumbar stenosis. I know today is about Parkinson's, but there was a Parkinson's piece to this. And this case number 2, this 80-year-old has to have supposed to fall while carrying a fertilizer tank down the stairs. No assisted device use. Left total hip replacement, takes Lasix for heart failure, caregiver stress. His SPPB was pretty crappy also. He had trouble with walking and balance and chair stands. The mini-cog suggested some impairment. He refused physical therapy. Hear that before? But he might do community Tai Chi. Now, there's data now. I don't know if you've seen a paper, probably about 6-7 years ago in New England Journal, a randomized controlled study specifically showing an improvement in certain parameters with Tai Chi in Parkinson's patients. Community dwelling, okay? have to keep giving that caveat. So I'm going to talk to you about Falls 101, key epidemiology and key concepts, and then some other stuff. I'm preaching to the choir here, right? Lots of people fall, at least a third residence. This is a community dwelling. And it's been an increase in rate of death from falls. About a fifth of falls cause a serious injury. Everybody's worried about a hip fracture, but in fact, people bonk themselves, bruise themselves, might break a wrist, have a head injury. Treating the ER frequently, total medical costs at least $50 billion is probably an underestimate. As I said before, lots of people are worried about hip fracture, but in the community, only 1% to 2% of patients have a hip fracture. Very devastating when it happens, but there's also other things, other fractures, other injuries, other bruises, like I said. And what's more important, I think, where am I? What's more important is that people can't get up after a fall sometimes, and they begin to fear of falling, and they decrease their activity. In case I forget to say this, I was thinking about this, this didn't wind up on your slides. There's something insidious about people with neurodegenerative disease that are in an assisted living, long-term care facility, even at home, that because of their deficit, they can't do things safely, and they become deconditioned. And I think we've really under-recognized that. And what happens is when you do something with them, they get better. Not a lot better, but they get better. So I want to encourage you that there's a constant battle against safe mobility and maintaining conditioning. I don't have any data on that, just kind of something we've been talking about. There's a guy named Bruce Dobkin, is that name familiar to anybody? Neurologist out of UCLA. He and I were talking about that about a couple years ago. Falls classification. So what do I mean by a fall? So that means they come to rest on the ground or lower level. It's not loss of consciousness, they haven't been hit or pushed over. And one of the teaching points today is everybody says, oh, they tripped over something. Must be something they tripped over, and the doctors will use the term mechanical fall. Anybody hear that term before? Don't use it. I should have a button that says mechanical with a slash through it. Because what really happens is that people have an interaction of multiple factors. Intrinsic, and Parkinson's patients, of course, have lots of intrinsic issues, balance problems and gait problems. But there's also things in the inner environment, the extrinsic causes, and they all compound themselves in situations. And that's where I think we've not done a very good, we've done some job, but not as good as we probably could in the community. Better job in the institutional setting or the assisted setting, where we're controlling some of these situational factors like lighting, like slippery surfaces. And so, as you might expect, in a nursing home setting, you see more intrinsic factors because people are more disabled. And in an independent setting, or in the community where you have free-range older people, they have more extrinsic factors. That was a joke. Anybody paying attention? Okay. Another teaching point. These Parkinson's patients, they're of the older ones that I see, they have a bunch of other things going on because they're aging. And we probably forget that. Actually, I was talking to one of my colleagues who's a movement disorder specialist at the university, and I think most of the Parkinson's experts don't really think through all the other stuff that could be going on with an older adult. And here's some of the things you might want to think about. So things that happen with aging: central processing delays, vision delays, not a lot of vestibular changes, some systemic changes like your blood vessels get stiffer, definitely weaker musculoskeletal, and then neurologic changes also mild. But these changes are dwarfed by all these other things that happen as you get older. I call them age-associated diseases. Again, repeating, relevant for Parkinson's patients because I think a lot of Parkinson's patients have, we call them comorbidities. So people in their 70s, Parkinson's patients who make it to 70s and 80s may have these other things to think about, like central processing changes, dementia. Okay, that you probably know about. Vision changes, cataracts, macular degeneration, glaucoma. I don't know if I'll get a chance to fully show the study, but if you remove one cataract, just one, that decreases your fall risk. Of course, you can see better if you take out two. Vestibular changes, I call your attention that because people have benign paroxysmal positional vertigo and that can be treated. Disease, so this is not a lot of physicians in the crowd, but I always worry that people who start falling particularly frequently, there's something going on. There's some disease. They have a urine infection. They have heart failure, something medical. Don't just, if it's out of their pattern, knowing, of course, that Parkinson's patients can fall very frequently, but you always kind of, in the back of your mind, thinking there's something else going on. Many people have arthritis, and of course, what the problem with arthritis is it doesn't necessarily make you fall down, but it makes you less able to move your limbs in the case of trying to recover loss of balance. We call those LOBs. Loss of balance. An unrecovered LOB is a, very good, thank you. And notice I put at the bottom all the neurological associated diseases, because everybody, all the physicians for sure, start thinking somebody's falling down, there must be something neurologically wrong with them. And they start looking at myelopathy. Myelopathy is a spinal cord problem, which, by the way, the first patient had a stroke, or PN is peripheral neuropathy. Lots of older people have, by the way, mild peripheral neuropathy. I think it's under-recognized. You have to take off people's shoes and socks to determine if they have peripheral neuropathy. How many doctors take off people's shoes and socks? Okay? And then, of course, there's medications. What are the medications that we really want to worry about? Now, recognizing that Parkinson's patients need to be on certain medications, but there are certain medications that retard alertness or central processing. Classically, analgesics like narcotics, psychotropics, benzodiazepines, we don't use those as much anymore. Phenothiazines, not as much anymore. Tricyclics, not as much as anymore. SSRIs, so these are like Zoloft and Celexa, and atypicals like Zyprexa. Thank you, Seroquel. Just think of Seroquel. You read my mind. One of the things I was talking to some of my colleagues right now is that there's been a movement away in institutional setting away from psychotropics, right? Trying to get away from this stuff. So they're trying to convince me, and you probably know better than I, you're trying to move toward behavioral interventions, which may or may not work so well. So people are using, on a short-term basis, things like Ativan, short-acting benzodiazepines, which we don't think, I personally don't think is going to be a long-term solution. It's a very short-term solution, can cause paradoxical agitation, can cause sedation. So I'm sure there's some docs doing it where you work, because that's what I'm told the epidemiology looks like. Everybody's so excited. We've decreased our neuroleptic use. We've decreased our use of Haldol and Zyprexa. There's data, good data showing that. But it sounds like people are using short-acting benzos. And if we have enough time at the end, I want to hear if anybody can confirm that for me. The other one, big one, is people taking, some of the medications that Parkinson's patients take make their blood pressure go down. Orthostasis, particularly if they have multisystem atrophy. Does that sound familiar? They have autonomic changes. But even people who don't have that, they have antihypertensives or diuretics that cause blood pressures to drop. So think about that. These medications, both these medications are particularly important in the during a short, earlier or new titration. When they start taking the medications anew, or if they're sick and they're not taking in fluids, if something's changed acutely and you keep them the same meds, that's when they get into trouble. But I can assure you, I don't want you to go out and go back to your facilities and say, we got to take everybody off these medications because they're on these medications for good reason, usually. In general, I think physicians, as opposed to maybe like maybe 10 years ago or 20 years ago when I first started giving these talks, physicians didn't know about this stuff. They didn't know, but now they've heard the gospel, and they're trying hard to keep people, it's called deprescribing, right? You've heard that term before? I would use the term safe prescribing. In other words, if somebody needs it, just be careful how you give it to them. And be careful under the situation, how they're doing when you actually give their medications. Extrapyramidal effects are really, we don't see so much from medications that much because we're being much more careful. Okay, extrinsic causes. This is Alexander's Hall of Falls. Whoops. Where are we? Oh, sorry, wrong way. So you'll see it. What am I, a Scotsman now? So there's, if I can do this. There's a shadow cast here, there's a wire, there's stuff in poor repair. I actually think people have done a fairly good job of trying to keep the home safe, and we've been told that, you need to go through a checklist of safety. The data is mixed on how this is effective in reducing falls. Generally facilities, assisted living, senior centers and institutional settings, generally I think extrinsic causes are less of an issue, as I mentioned before. I think situational factors are still an issue. So when somebody collides with an object in the dark, how do you stop that? Turn on a light. Okay, night lights. Changes in friction between the shoe and different flooring. So, I don't know, was there linoleum out there? I mean, it was all carpeted. And door thresholds. I think we solved that in an institutional setting, but maybe not so much in the community. So this is a hot topic right now. I'm going to get into the hot topics now, which I think is a big deal in Parkinson's patients, particularly Parkinson's patients with cognitive impairment. It's this kind of behavioral stuff, like they didn't recognize a temporary hazard situation. They're distracted by another task. Anybody know anybody like that? Dual tasking, multitasking. We're worried about it in the car, but we're not worried about it when we're walking. Maybe we should. Inappropriate behavior in potentially hazardous environment. You know, there's actually papers in not so much Parkinson's, but Alzheimer's patients who, you've heard use the term impulsive. They're going way too fast because they can't stop themselves and they can't keep themselves safe. So these are the kinds of things, not that I have an answer for these so easily, but at least we have to recognize that this is something that's going on and it's been noted in the literature. Activity results in a displaced center of gravity, so they're pulling a drawer and suddenly accelerate backwards, they're pushed or hit, carrying heavy objects. There's no reason that some of these patients who are very frail should be carrying something. I don't know, this makes me nuts. At least nothing very heavy, put it that way. All right. So again, this is community setting, so I apologize for some of you who don't practice in a community setting, but I think this is probably true it's certainly true in a hospital setting. Anybody know what the Morse scale is? The Morse Hospital Fall Scale? A show of hands? Not so many. So actually that calls to mind, I'm thinking in senior living, in assisted living, and in long-term care, not so sure we have these kinds of scales that are fall risk scales that are all that great. But so the most important factor on that scale, and I dare say with any scale, if you fell before, look at the top here. This is a collection of studies, and the risk ratio and odds ratio falls. This is about almost 9 years old now. But if you've fallen before, guess what? That's the highest risk factor of falling again. That seems kind of duh to everybody, but that's a common risk factor in all the scales that I know of. Balance, strength, vision, of course. Psychiatric meds we talked about. You know what? More than 4 meds? I'm on more than 4 meds. So, everybody's on. If you follow guidelines for hypertension, heart failure, all that stuff, you're going to be on a ton of meds. What else to show you? I think the interesting thing about this one is that, let's see, show you down here, impaired cognition. So only 3 studies, low risk ratio. So the problem is when you do a community-based study about falls, people have to fill out that they fell down. In other words, they have to have a brain. They have to be able to respond and remember that they fell down to tell the researcher that they fell down. So impaired cognition is underplayed in the community setting. I think that's the problem with this review. Okay, the big topic, which I've been interested in, a number of us have been interested in, is when does a fall cause an injury? Because you want to stop a fall, of course, but you really want to stop an injury. And unfortunately, we don't really know all that well how to do that yet. But here's some thoughts about what's it necessary for a fall to result in a hip fracture. So audience participation, woman on the left, woman on the right. Which one has a higher risk of having a hip fracture? Right or left? And why? Forget the stairs. I heard somebody said stairs. I shouldn't have put them in there. The one on the right? Who says that the one on the left is going to have a hip fracture? Who says the one on the right is going to have a hip fracture? Who doesn't know? There you go. Okay. So the one on the left she's got arms out, legs out. She's gonna find a way to break her fall. She may break her fall with her wrist, and a broken wrist. The woman on the right, this is almost a Jewish Sabbath, is doing oi. This is an oi reaction, and she's saying, oi, I am twisting, I am not using my legs, I'm not using my arms, and she's gonna fall, and the worst thing possible, here you go, whoops, oh man. Worst thing possible is she falls on this smack on the greater trochanter. People who have a lateral fall, it's thought to be that's the worst fall you can have. So ladies and gentlemen, if you have a big tush, yay, fall on your butt. It's safer. Unfortunately, we see a lot of older people who fall forward and they hit their head and they can't get their arms up quick enough. We've actually done studies in that. So this also represents, this panel also represents this kind of floor down there. I didn't push it very hard, but I think there's probably cement under there. That floor is hard enough for anybody with osteoporotic hip to fall down from a height of 1 meter, in other words, 3 feet standing, to break a hip. This panel over here in the far right is where all your doctors are. They're stuck on bone. I want to build bone. So I'm giving you bisphosphonates. I'm giving you Prolia. I'm giving you, but it builds some bone, but that's probably not enough. This one was the tushy one, where you have, if you're really thin, maybe you look great because you're really thin, but you don't have any protection. And people who are really emaciated and don't have any fat or muscle are at higher risk for fracture. This is where I think we need to work on. We need to stop the OIs. And I'm not sure exactly how to do that. We're actually thinking about how to do that. There are some people who are doing late stage fall response training. In other words, you're about to fall and you're just supposed to learn how to relax and just fall. And by the way, I am sure that there are a number of Parkinson's patients that you know of that fall all the time and they're still doing okay. I mean, they're still kind of making it. Because what I always say is all falls eventually stop. Sadly enough, okay? If they really have a bad fall, they're going to stop falling because they're going to injure themselves and they're going to become so immobile they won't fall anymore. So anyway, that was not meant to be funny actually, but yes, okay. All right, fall risk evaluation. So what do you do? History. So I'm going to go through this quickly. This is something that you probably. This is rising from a lying or sitting position. We're always worried about people having orthostatic blood pressure changes, right? How many people work in a facility where they do orthostatic blood pressure changes to check on people? Really? I'm impressed. How many do it from a lying to a standing? Ooh, very slick. So that's really the appropriate way to do it, lying to standing. And I can't even, because older adults have autonomic heart rhythm changes or heart rate changes, I just look at the blood pressure drop of 20 millimeters or more systolic, which a lot of older people have anyway. But I also look to see if they're symptomatic. Am I able to reproduce their symptoms by getting them from lying to standing? This is not a lecture on how to treat orthostasis. That's actually that's a challenging situation. Okay. A trip or a slip, lots of your people are tripping or slipping. How do you fix that? I don't know. But remember, it's not just the fact that they're catching their foot. There's something else going on. They can't see it. They didn't plan for it. They didn't lift their leg high enough. There's sensory loss. It's just not, it could be a gait balance or vision disturbance. It's not just the fact that you just, oh, they're Parkinson's, they trip. That's maybe a too simplistic approach. Post-cough urination, recent meal, not so much. Looking up sideways, not even going to go there. There's a literature on carotid hypersensitivity where people wear tight collars, and I'm not going to go there. Leg catches or gives out unstable. I think we don't really recognize that as much. People with arthritis or pain in the limbs. Dizziness, a new syndrome. So I'm not speaking to all practitioners here, but I struggle with making sure that I find people that have vertigo. If things are spinning, if you're spinning or the room is spinning, that's a whole different workup. That's a whole different treatment. And a lot of your patients are going to feel lightheaded or funny, and it's kind of pre-syncope. They're orthostatic, they have a dysrhythmia, they have an anemia, or other stuff, sensory loss. So it's important really to distinguish if your patient tells you that things are spinning, tell the doctor, tell the practitioner, because that may be a different workup and a different treatment. Okay. Exam, mental status, of course, orthostatic blood pressure and pulse we talked about. A Hallpike-Dix-Browning maneuver, that's to get the positional vertigo. I'm not going to show you that. Vision screen, carotid auscultation, listening to the heart. Joint and foot deformities, I'm a big believer of that, particularly in the spine. I have a lot of patients, and especially Parkinson's patients, their trunk, their spine is stuck. It is not moving. And when they fall, when they lose their balance, They can't bend, they can't turn. So that's a big deal. Neurologic exam. Strength and tone, of course. Sensation. Again, I think, so I have a different practice than your neurologist that you work with. The neurologists are like focused on Parkinson's. But to me, if they come to me, I have you're tired, you're poor, you're falling, masses yearning to be upright. That's the ones who come to me. Another joke that was missed. They come to me, and I think, if you're coming to me, I know you know it's Parkinson's. Let me see if there's other stuff going on. And people have some loss. They may have mild proprioceptive or peripheral neuropathy changes. Not that I can fix this so readily, but at least we identify that as part of the process. And then station and gait. So I know the Parkinson's, our guys in the movement disorders do the pull tests, looking for a postural response. I don't get it. Any neurologists here? Yay, I can talk freely. So I don't get it. How do you know how hard to pull them? And if you have bad Parkinson's, what do you think you're going to do? You're going to fall like a log. What's more important, a kind of functional test like the Romberg. Romberg test is feet together, eyes open. That's not the Romberg. If I can do feet together, eyes open, that's good. If I can't do it, what's wrong? A bunch of things. Now, if I can do this and I close my eyes, and now I step out, if I step out with my eyes closed, then I'm thinking, well, they did okay with their eyes open, but when they lost their visual referent, they're reliant upon their, not that they're crazy, their inner ears and proprioception, their feet, okay, classically. So that's helpful to me to understand that there's something else going on that's a sensory piece, not just a motor piece, okay? Now the other piece I get, now again, it may not be relevant for this audience, but I have your worried well that people's tennis game isn't quite as good as it used to be, and their balance is off, so I test them with a one-legged stance. One-legged stance, foot is like this, no storking or flamingoing, this is a stork or flamingo, no stork or flamingo, 30 seconds, eyes open. I'm making the recording guy crazy. 30 seconds, eyes open, each leg, see ya, good balance. Eyes closed, try it after my talk, not so simple, okay? A number of you will have trouble with eyes closed. So less than 5 seconds, time unipedal stance, a lot of my sick patients have that problem. So it's not, but it is a high risk for fall injury. And then I look at walking, and I was going to have you go through a walking evaluation today, but I dare say you probably know when somebody's walking funny, and if anybody's walking funny, they probably need to be evaluated. And I get a lot of people with funny walks. Funny meaning not humorous. I mean, they look odd. Okay. State of the art on falls. How am I doing on time? I have till 4 o'clock, right? Just kidding. Cow, you guys. How long do I have? 3:15? I'll leave some time for questions too. So what is it now? 2:40. I'm rolling. So the steady algorithm. Have you heard about this? This is, again, for community dwelling, not so much for more frail people, but they ask people if they've fallen in the past year, do they feel unsteady when standing or walking, and they worry about falling. Oh, for God's sake, everybody's going to be positive, right? So this is the first critique I have of this. But again, this is the state of the art, folks. Community dwelling now, okay? So what do you do? No, if they say no to you, first of all, I don't believe them. So forget that one. If they say yes, well, we need to have some sort of gait strength or balance test. How many of you actually do the tug, the timed up and go? Is it all that useful for you? It's a screening test. If you're a therapist that help, it may be one. The therapists have much better batteries, like the Berg and Tinetti maybe. They have better ways of evaluating progress. It's a very crude screener, but you need something that maybe you used it. Actually, when I watch people come in my clinic, I can tell already that they're not doing well. And by the way, the original timed up and go was a qualitative evaluation, not timed. It was a 4 or 5 point scale, if I recall correctly, depending on how badly they did. Anyway, let's say they didn't, again, no, they're okay then, which, again, not your people. Okay, let's say they have a gait or balance or problem. So what you do, you have no falls, and they go to this there, they have one fall, don't worry. So let me just show you, let me go back a minute. No, everybody pay attention to this. This is where the action is. If you've had 2 falls in the last 6 months, let's say, or you hurt yourself in a fall, you go through a multifactorial risk assessment. I don't know how well that relates to people in assisted living or an institutional setting, but this is basically what we have as a consensus conference guideline for the community. That's it. And then the evaluation I've already shown you, or I will show you if I haven't shown you completely yet. Okay. So we determined fall risk. I showed you all this stuff. I didn't talk about feet and footwear. Anybody do you look at your residents' feet? Not if you can help it, probably. They're messed up. Every day I have a patient coming in my not every day, every Wednesday I have falls clinic. They have gnarled feet, their toe flexors don't work, they have painful feet, they have insensate feet, they don't feel with their feet, which is the peripheral neuropathy. So that's an important piece. I can't fix that, but at least I know about it now. Maybe I can start worrying about it. And footwear, what's the proper footwear? Stiletto heels? Crocs. Thank you. Another Croc aficionado. No, thank you. Non-skid soles, low heels, shoes that actually fit, and maybe something you haven't thought of, but shoes that have a backing that cover the heel. In other words, no slippers. You probably know all this stuff already, but I'm just saying, it's not really well promulgated about what kind of shoe. And then they have the usual SAS debate. The SAS shoe debate. SAS shoes are sticky. They can catch, especially for somebody who shuffles, right? Who's a shuffling gait. What do? I don't know. But you got to find, you can't give them non-skid soles. You can't give them slippery soles. Then the shuffle becomes a slip. All right, what else? We talked about all that stuff. So what do you do? So your doctor, a bunch of falls, and your doctor says, oh, let's going to do a workup. What are you supposed to do? EKG, head scans, blood tests? We don't know. Well, a doctor's supposed to do a very careful evaluation of all the risk factors that I'm talking about and kind of see what he needs. Unfortunately, when they get to my clinic, people have been worked up already, I guess fortunately or unfortunately. I rarely order anything. Although sometimes I may order MRI, but for other reasons. There's a hot area right now. You know that Lewy body dementia, I know people have Lewy body dementia, people know about Lewy body dementia, but in dementia, to me, and cognitive impairment is kind of messed up because there's a vascular, they're not really, they may be strokes, but there's a vascular confound. Lots of people that we call Alzheimer's, lots of people we call Lewy body, lots of people that we call frontotemporal dementia have a vascular component, right? There's blood vessels that have been messed up. We call them white matter changes. It depends where it happens, where it hits. And part of the problem is that it not only affects their thinking, it affects their balance. So people really don't talk about that very much. In the old days, we used to have MRI scans. I used to get the reports, normal for age. Really? Well, they don't say that anymore. Stop saying that. Okay, what do we do in the community for interventions? So, education, minimize meds, you know this stuff. Exercise. Oh, what exercise? We're going to talk about exercise in a moment. Treat vision, I mentioned the cataracts. Vitamin D, oh my gosh. How many people are giving that really think that vitamin D is a critical, important part of their fall risk reduction? Nobody raised their hands. Oh, okay, a couple. Okay. Well, the U.S. Preventive Task Force just recently downgraded vitamin D to a class D, if I'm not mistaken. Huh, that's funny, D to D. We have known for a long time that vitamin D is in many tissues. We've known that it may decrease hip fractures. It may also, for some reason, decrease falls. It's just not bearing out. And classically, the last group of patients that we thought vitamin D would be beneficial for is in a nursing home. And I don't really know the data so well in a nursing home, but it's not working for the community. I'm not sure it's going to work for a nursing home. One caveat is that if people in a nursing home or an institutional setting don't have exposure to sun and maybe have very poor nutrition, so maybe they have osteomalacia, not that common. So vitamin D, with all this hoo-ha I just told you, I should tell you that a number of bodies, the American Geriatric Society and Osteoporosis Society, still recommend 1,000 units or more. That's not a lot. It's like 200 to 400 in a vitamin. So, rhythm, we're not going to talk about postural hypertension, we're not going to talk about foot and footwear, we're going to talk about modify the home environment. Oh, by the way, I know people practice, you know, that the edge is an educable moment when people when they bust themselves up and they're in the ER, and you send them home with an occupational therapist. Any occupational therapists here? Yay! So and I love occupational therapists, and a lot of the new stuff coming out about falls and improvement of disability is using the occupational therapist, not the OT who comes in and does DME, the DME OT, the DMEOT, but the OT that goes in and says, and works with them for energy conservation, pacing, safe mobility, ADL stuff. Okay, I see some nods. Anyway, a healthcare worker like that goes into the home after an ER visit with a cognitively intact person or reasonably cognitively intact person is thought that's the kind of intervention. When you modify the home environment, it's not so much they're modifying the home environment, I think, it's they're modifying the person's interaction with the home environment. And I'll talk about that more in a minute. Any PTs here, by the way? I didn't mean to slight the PTs. You guys have had it in the sun forever, okay? It's time for the OTs. Treat underlying diseases, okay? I'm just riffing here, trying to keep people awake. So one of the things, if you got these factors here, a couple things. I was really disappointed when Medicare limited outpatient PT services, you know, the amount of money, and we actually broke up. I had a PT that I practiced with in my Falls clinic, and we had a terrific thing going, and so I can't do that anymore because it doesn't fit the payment model. Nevertheless, I do liberally refer, and not just for exercise and for, quote, rehab, and I give specific things, but also for assistive device use. This is behavioral change. I'm not fixing their legs, but I'm fixing the way they use their legs and their hands in a safe manner. It sounds OT-ish, doesn't it? Yeah. Sorry about the PTs there. PTs are great. And here's a good example. So if people are dizzy, they have a PT habituation or particle maneuvers for benign perceptual vertigo, cognitive loss, different lecture, foot problem, footwear we talked about. Vision, oh my God. So we're doing this national study, and the official party line is, you know, if you have bifocals or trifocals, you're at risk for falls. Well, everybody in Ann Arbor has what are called, because they're so smart, they have graduated lenses. Another bad joke. So, you know, they seriously have, people have graduated lenses. So when traditional bifocals or trifocals, when they go downstairs, they're like going like, where are you looking, right? Which part are you looking at? So that's where I think where this issue comes from. So they told us, have people reading, not reading, reading, not reading. I said, give me a break. So this is unclear what we're doing with this exactly, but there is a literature you should be aware that people with bifocals and trifocals classically are said to stop it and then change lenses. I made that up. Osteoporosis and low BMI, different lecture, medications, we know what we talked about. Okay, exercise, Tai Chi. I mentioned Tai Chi. Have people seen that article in the New England Journal? It's actually done by this group in Oregon. I forgot his first name. Fuzhong Li, I think is his name. Anybody seen these papers? Likely, if you've seen a randomized controlled study that shows some positive effect of Tai Chi, it's likely the Oregon group of Fuzhong Li, okay? That's not to say it's bad, it's just, they're experts in it. You know, but the question is what about other forms of Tai Chi that are done by less expert people, like your neighborhood Tai Chi person, or your westernized Tai Chi person, or worse yet, you ready for this? Your chair-based Tai Chi? Certainly somebody's doing that. Here, tell me you're doing this. Yeah, it's called what? Soft Tai Chi. Soft Tai Chi, it's like soft shoe. Also chair-based yoga, same idea. So it takes away the fact that you stand in stances when you're most at risk. So it takes away that whole benefit. Don't get me wrong, exercise is good. Anything you do, any activity is good. It's just if you want to decrease falls, you got to do this. These are the best practice exercise recs. Now these are, again, I caution you, these are not for an institutionalized or assisted living group, but the data we have is not all that good for exercise in those participants. So this is from community dwelling studies. So moderate to high balance challenge, sufficient dose, 2 hours per week times 6 months. Ongoing exercise, you use it or lose it. Boy, have you heard that before, huh? Especially, and there's data suggesting this. General community as well as those at high risk. Group is okay, home base still works. Oh, here's a good one. I'm gonna go out and walk, or I'm just gonna do some stretchy bands. Is that enough? We don't want to take me on because you see it that says it's not. So you have to have some sort of balance. So it's good to get your patients, your residents walking. It's good to get them to do some sort of activity, but remember, it's not thought to be as effective as a balance, some sort of balance component. Now, CDC, if you go on the CDC website for community-based exercise to reduce falls, they'll talk about Tai Chi. They'll also talk about something called Otago. Has anyone done Otago? It's not popular in Southeast Michigan. It's actually pretty sad. Otago is a kind of a dynamic balance program that's not really penetrated the United States very well. I'm actually, my people are certified in it, my trainers that work with on our research projects. But for your benefit, Tai Chi. Now, Tai Chi, for those you don't know, I'm about to do a bad version of Tai Chi. Very bad. But I'm using arms and legs. I'm going cross, weight shifting, cross my left or right side. If I do it right, I'm supposed to have a cognitive or a component, a brain component. My brain is engaged. We call it, we actually do studies like that are called moving mindfully. That's how you're supposed to do it. You're not just going to go, You're supposed to really, I'm moving. Okay, that kind of stuff. Okay. What's the data show? So this is a little older data. This shows if you do the multifactorial assessment intervention, this is the effect, 11% effect. Exercise to PT, 15% effect. Vitamin D is 17% effect, but now it's called into question. Look at this one, psychiatric med withdrawal. That's a good one. 66% of reduction in falls. Wow, that's good. Look what happens though. 47% of the placebo people see, they want their meds back. They want their meds back because the depression, the anxiety, the hallucinations, whatever was being treated, it was not a realistic model. I think I have another slide. Okay, so this slide here is another. This was a network meta-analysis was in JAMA, virtually unintelligible paper. Okay, but this is the table that I generated from it. Falls are in blue, or reduction, and fall injuries in black. So you want to see lots. So exercise, look at that. Got lots of blues and blacks. Not so much in the other one so much. Patient QI, education, not so much. Anybody using hip protectors here? Yeah? Yeah. Data is not supporting it. Unfortunately, the VA, I was just soundly reprimanded that it's part of VA policy in our that we can use them. The data is never really borne well on that, and I don't want to go into that. So anyway, I think I have a section here. Oh, here, exercise training to reduce falls in PD. Can you see this? This doesn't project very well. Oh yeah, I can't even see it on mine. So if you see here, you want to try to, if I see it. So favors exercise to the left here, so it suggests that favors control to the right. So it looks like it's good. These are in long-term basis, and basically I think I show you this one. So this is 6-week multimodal, follow-up 18 weeks, 12-week balance, 10-week multimodal, balance. Multimodal meaning there's a balance piece to this, okay? So there are studies that exercise training can reduce falls. I don't know why I didn't show that. I didn't give you the Tai Chi study. So there's and the data is not so clear. It says 60% reduce the fall rate, weighted by one study in particular, non-significant reduction in number of fallers, facility training better than home. So again, you probably should be doing exercise in your people. There's probably some data suggesting it. Do you have this slide? You have this one? It's probably equally unintelligible to you as well as I. Okay. This is the one I was talking about, doing some sort of educable moment with an OT and working on efficacy and behavioral change, and do some balance and strength exercises. And what happens is you reduce falls. This is Lindy Clemson in New Zealand has done a lot of good work in this area. This is the moving mindfully piece. By the way, we've tried to adopt this in the real world. It's not so simple, but there are certain this is something you can tell your patients or participants or your residents. Red activities are something that you should never do. Green ones you can always do because you'll never lose your balance. And yellows are the ones where we spend a lot of time focusing on. When you're on stairs, it's a yellow light. You do it when you're not fatigued. You walk step to step using railings when it's well lit and edge contrast. All right, in the care facilities of hospitals, how much time do I have? Okay. I actually should have looked this up again. I don't remember. I don't think I've seen a lot of things to change my mind about this, but there's an inconsistent effect in nurse care facilities. Hospitals, there is some RCT reduction, but again, inconsistent effect. The best outcomes are in the post-acute or longer stay hospitals. You know, if you have somebody for 5 days in the hospital, you don't have enough time to do anything. So post-acute is an opportunity. So there are some of the data in there. Nursing home is small, probably insignificant. Best effects of vitamin D. I think the best thing that I've seen thus far, I think is probably the most robust, is pharmacist medication review. Even though I said that we've heard the gospel about medication, and by the way, we're right now reviewing all our medications in our post-acute unit, so I'm not sure this is necessarily true, but apparently this is what Cochrane said a few years ago, the Cochrane review. And it's hard to disentangle the most important factors. In those with severe dementia, we have no idea what works. I'm sorry to say that you probably wanted me to give you the answer for dementia. I don't have one. Actually, I do have one. You have to have a system. It's not the person. You can't fix the person. You have to figure out, you have to fix the system. And I don't know if we're able to do this. We have enough money and time and technology. I think technology is going to be an answer, and we have we're working very hard on sensors to do this stuff, but still we haven't figured it out yet. Exercise might have an effect on subacute, but it's inconsistent. And in hospitals, there's all these things like we need a more intense implementation, we need to look at all this other stuff, and it really never borne out all that well. I'm sorry that I'm not more positive. In the UM hospital, nurses, there are a lot of nurses here, right? So there's something called the Yoda Index, which measures nursing clinical judgment, and nursing clinical judgment beat the standard scales, like the Morse scale. Yeah, give yourself a hand, or just one hand. Just clap in midair. Give yourself one hand. Our experience was we have these tools we use, universal. We figure if you're sick enough to get in the hospital, you're sick enough to fall down. That's probably true in any facility, any assisted living, any nursing home. If you're sick or frail enough to need that kind of oversight, you're probably sick enough to fall down. One of the things we did was focus on risk factor specific care plan. I have not seen this in a long-term care environment, but I wonder why, if it could not be used. And we basically, this is a crosswalk of the Morse scale. Remember I mentioned history of falls as an important factor? Change in mental status, elimination. We're not eliminating the patient, that's bowel and bladder, balance and gait, and neurosensory deficits like dizziness, making sure they have their glasses, their hearing aids. And so here's the crosswalk that we use. This is inpatient, okay? And we have something called proactive elimination. I don't really know if this works all that well, but the idea is you bring them to the bathroom before, so they don't wander off in the middle of the night going to pee. And I'm sure a number of you have these Q2, Q4, whatever protocols and people, if they, I shouldn't say this, but some of the nursing literature has some support of this, but it's not all that good. Okay, then it's not, the data is not all that great. This item is an interesting one, altered cognition, non-compliance with the need for supervision. Who's seen that before? And a lot of what this intervention here, look to the right, what is this? This is a delirium intervention. So you want to keep people from getting more confused by, getting them orientation, contributors to delirium, and of course you do things that enhance surveillance, which is what I was getting at before. And then the vision, hearing, and position sense stuff. Okay. Again, I mentioned universal falls precautions, the 5 Ps, pain, potty, positioning. This is if you're a nurse doing good care, you're going to do this, and that's the bottom line. Other intervention with limited effectiveness, restraints in bed rails. This is old news to you guys. For years, we've not been able to do this because it doesn't stop injuries. Sitter use, oh my, hot topic. And I'm not prepared to talk about the video sitter extend. I call them sitter extenders. Any of you use these video thingies that you monitor people from, like the guy behind the curtain at Oz, is watching the video, watch out for those because the companies are purporting that they are fall reducers. The data is not, I don't have anything about it because there's really no good data. We, at the falls committee at the university, we think they're sitter extenders. And if somebody is directable, if somebody can hear a voice coming over a loudspeaker, Mr. Jones, get back to bed. Now, of course, if they don't have auditory hallucinations, they probably now have I think they probably have auditory hallucinations, but Mr. Jones is directable, then you can use it. But it's a very limited effect. So in sitter use, we actually, what the sitters can do when proper training, maybe this is not so relevant for you guys, but we are in a process of trying to look at that in a number of hospitals. Low beds, floor mats. I'm sure all of you do this. Does it work? We don't know. You know, our beds wander. Actually, I think we're now at the university now moving all of our low beds now, or almost all. Bed alarms. Ooh, there's a good one. Do they work? Sometimes. So bed alarms, my buddy Ron Shore did a very careful randomized control study, inpatient hospital, if not effective reducing falls. A lot of it has to do with how quickly you can get to them, right? Most of our guys, as slow as they move, you know, once they activate that alarm, they're gone. By the way, there's some, I should, oh, why not? There's a company that's suggesting that you should wear alarm socks, that once the feet hit the floor, then therefore it should trigger alarm when you come running to them. Man, if their feet are on the floor already, the horse is out of the barn. That is way too late. Okay. And then delirium prevention. There's something called the Elder Life Program. I don't know why no one has tried to do a delirium prevention program or try to optimization of cognition using these same techniques with the long-term care population. Maybe it's not, maybe nobody's thought about it, I don't know. But this is hospital stuff. Okay, this is what we did. This is our STRIDE program. Just completed this randomized controlled trial. The nice thing about this is that this is embedded in a practice using a falls care manager. You've heard of a diabetes care manager? You've heard of a heart failure care manager? We had a falls care manager, and we prioritized what the patient wanted to fix. I don't have the data with me, and look at the time. But I think it's, we'll see what happens with that. I don't know. Okay, your one-year follow-up, the guy with probably some Parkinson's and some lumbar stenosis, 4 falls since entry, last fall down a narrow station, he discharged from PT. He did LSVT. Big steps, screaming and big, make them big and screaming loud, and continues to do treadmill walking. Let's see, he continues hypophonia, isn't sure cinema helping, feels short-term memories decline. So there's an inexorable cognitive impairment that comes with Parkinson's, correct? Not everybody. It's a subcortical dementia, or they actually get Alzheimer's as well. Examine change. His SPPP though improved significantly, and his mini-cog improved. So he wants to take the big exercises. Anybody know, our LSVT is very intense that we do it in Ann Arbor. It's a 4-week, 5 times a week thing. Am I saying that right? 4 times a week. We now have a group LSVT out for those graduates. Have you heard of that before? I thought that was an interesting idea. I don't know, I recommend, I don't know the data on that, but we're doing that. Case number 2, no falls. Tai Chi, okay. You know, I actually think, remember I told you about Tai Chi's being great? Let's say you can't get out, you have trouble getting out, or you don't want to go out to the exercise. Once you learn it, there's a lot of home DVDs that people use or TV-based follow that they do. Adding shower bars, grab bars, throw rugs. Let's see, improved his SPPB, improved his memory, more PT. Wait, is that the same guy? Oh, okay. Anyway, future directions. So summaries, falls can be reduced, not actually prevented. I didn't probably say that as clear as I should be. Falls risk associates with comorbidity and disability, not just age. It isn't just an inexorable thing of aging. Evidence-based interventions vary in quality. What works in the community may not elsewhere. Consider risk for injury, all those in a hospital, and I dare say the environments that you work in, they're all at risk, universal coverage for all, customized plan for some. And cognitive, I'm not going to make you happy, but we're still not there yet, and we need to identify the cognitive behavioral factors, particularly in long-term care, that we haven't fixed yet. We're working on it, but it's not fixed yet. And then this is my clinic. Again, the tired, the poor, the falling masses yearning to be upright. This is what we do we have PT, social work sometimes. What else to show you here? Let's see. Oh, in case you were sleeping through this whole thing, wake up, because now I twisted somebody's arm. One of my patient's daughters was a writer for Our magazine. I said, will you do something with what I do? Just because I say this stuff and no one's ever kind of written it down. So somebody wrote down some of the stuff that I said. That's me, of course. And this is, from 2017, you can look it up in Our magazine. Most of my famous articles, they're carefully buried in the literature that nobody can find. They are published, but they're carefully buried. Not on purpose. That's just how it goes. And so you can look me up, and if you forgot what I had said. And then that's it. Thank you. So it's your choice. I've given them 10 minutes of their life back, if it's up to you. You can take it away.
Any questions?
Yes.
Okay. Anybody have any questions? Here you go.
So I know your talk was mostly focused on people who live in the community that come in.
Yeah.
How does alcohol use play a role in the assessment and intervention? I didn't hear that mentioned in your talk.
You didn't hear, so the question was, what about alcohol? Why didn't I mention alcohol? For good reason. It's unclear exactly what to do about alcohol in a fall risk. I'm open to suggestions about people telling me, well, I know this guy is always falling. Does he injure himself? Maybe, maybe not. The literature is very unclear about what to do with alcohol. And they don't self-report, and they're used to being tippy. They find ways to adapt. I don't know all the mechanism. It's kind of a mystery. But I don't do it routinely because I don't think it's going to help me. Thank you for asking that question. Yes?
Did you raise your hand? No. Okay. Any other questions?
I think they want to wrap up and get out of here.
Okay.
But you didn't. Most of you stayed awake. Thank you. Yes?
This is just anecdotal.
Anecdote.
I started Tai Chi in January. My balance is phenomenally better since I've done the Tai Chi class. I go twice a week. It's been a wonderful addition to what I do.
So we have a comment here that Tai Chi twice a week to a class. Do you also practice on the off days? So you practice. Classically, people who do Tai Chi with the classes 2 or 3 times a week and do home practice up to 20 minutes a day, maybe? Maybe 15. It's a powerful balance improver. Yes?
What is LSVT? It's in your...
Loud. Say, what is it? So there you go. Lee Silverman, vocal therapy?
Big and loud. It's talking big and talking loud for Parkinson.
Yeah, but it's so.
There you go.
So it's say it again, Lee. Lee Silverman voice therapy. Someone actually knows what they're talking about as opposed to me. We call it big and loud when they're basically getting vocal as well as stepping training, but we've always said I've always thought it was big and loud LSVT. I've always heard it offered that way anyway. Is that it?
I think that's it. Dr.
Thank you so much.
Alexander,
Appreciate it.
Thank you so much. Wonderful.